Thank you. We're just giving a second for people to roll in. And I see we have around 77 participants already online. Thank you so much for that. And without further ado, I would like to start this event today. My name is Tabinda Sarosh, and I've been working for Pathfinder for 7.5 years. And currently, I serve as the president for Pathfinder for the regions of South Asia and MENA, which is Middle East and North Africa. Welcome, everybody. I would like to start with our dear government representatives of DRC, Uganda, and Bangladesh. Dr. Sarah Byakika, Commissioner for Health Services Planning, Financing, and Policy. Uganda, Dr. Mbongani Kabila, Coordinator of the DRC National Council on Universal Health Coverage, and Dr. Shamsul Haq, Program Manager from the Ministry of Health and Family Welfare, Bangladesh. Dear UN representatives, through Professor Ki-Zerbo, the head WHO Liaison Office to the African Union and Economic Commission for Africa, and through Judicial Elidie, resident representative and head of office UNFPA, Burundi. Thank you so much. Ladies and gentlemen, welcome to the webinar on Universal Health Coverage Day Celebration 2023. We've come a long way. Universal Health Coverage Day, celebrated on December 12th each year, provides an opportunity to raise awareness about the importance of UHC and promotes actions towards achieving it. This year's theme, Health for All, Time for Action, also urgently reminds us that in a world that continues to experience a growing number of climate-related health threats, now is the time to invest in resilient health systems that will ensure health for all. This virtual webinar is to celebrate the Universal Health Coverage Day and use it as an advocacy platform to raise awareness on the UHC Global Monitoring Report, which provides the latest updates on global progress towards health service coverage, SDG 3, 8, 1, and financial protection, SDG 3, 8, and 2. Pathfinder's commitment to universal health coverage is instilled in our very vision, a world where everyone has access to contraception, where there are 0 new HIV infections, where no woman dies from preventable pregnancy-related complications, and where everyone leads a healthy sexual and reproductive life. Sexual and reproductive health and rights are a crucial part of achieving UHC, allowing people to attain good health through ready access to needed health services without financial impediments. Our strong local networks in the countries where we work serve as a platform for building more resilient health systems capable of offering sustained sexual and reproductive health care and other essential services, even in the most difficult environments. Country governments have the primary responsibility to ensure people's health, but governments alone cannot achieve UHC. The need is so great. The whole of society engagement in government processes and through social participation mechanisms, we ensure accountability and legitimacy. This webinar, which brings together ministries and health officials as panelists from different regions, Asia, Anglophone Africa, and Francophone Africa, and they will be sharing with us their UHC experiences, successes, achievements, challenges, and lessons learned, and more importantly, recommendations of actions needed to accelerate progress. Together, we can work towards a healthier and more equitable world. Ladies and gentlemen, thank you all for joining this important event. This event will be facilitated by my colleague, Pamela Onduso, Pathfinder Kenya Country Director. She will lead the panel discussion after the keynote address. I now have the absolute honor of inviting our keynote speaker, Professor Georges Alfred Ki-Zerbo. Professor Ki-Zerbo currently serves as the head of the WHO Liaison Office to the African Union and Economic Commission for Africa, a position held since November 2021. Before then, he was the WHO representative to the Republic of Guinea based in Conakry. Thank you, and over to you, Professor.
Thank you very much, Tabinda, and I would like to stand on existing protocol and convey my gratitude and appreciation for being invited on behalf of WHO to this important conversation about UHC Day 2023. I would like to greet respectfully member states representatives from DRC, Uganda and Bangladesh. Greet you as the president of the regions at Pathfinder, my UN colleagues, UNFPA representative in Burundi, our facilitator, Pamela, and all participants and dear friends. As you have rightly said, the theme of the year for 2023 for the UHC Day is Health for All, Time for Action. I think it's important to recognize that post-COVID-19, we need to really look at the lessons learned from the response, and especially the need to emphasize preparedness and contingency planning in terms of mitigating and preventing as much as possible the impact of health emergencies on universal health coverage. So we want universal health coverage in time of peace, if I may say, but also in times of conflicts, in times of crisis due to climate change, crisis due to the compounded conflicts over the globe, crisis linked to cost of living and threats to livelihoods, but also, as I said, the impact of fragile and complex settings on the health of the people. If you look at the African continent, we have several hotspots or even regions. You take the Horn of Africa, you take the Great Lakes, you take the Sahel region. These are places where the vulnerabilities are very high. So it's very important in this context to look at the meaning of the WHO Global Program of Work, the 13 Global Program of Work, which is now ending and which will be replaced by the 14 Global Program of Work. In any case, the three pillars of universal health coverage, health security, and health and well-being through the life course, also taking into account social, cultural, economic, and even commercial determinants of health, is very important. It is important that we recognize the negative impact of the pandemic on some of the indicators of SDG 3. And it is also important to recognize that the epidemiological transition is a reality in Africa. So beyond communicable diseases, you have an epidemic, you have a silent epidemic of non-communicable diseases, whereby we need to also have a package that is holistic, that is decentralized. And the issue of localization is very, very important. We are 7 years from the 2030 SDGs term, and the challenges are still very important in terms of accelerating towards UHC and health security. This is why I think the data-driven, evidence-informed interventions and strategies, the issues of policies and systemic transformation must be put at the center of the UHC agenda. For example, we know that extreme impoverishment due to healthcare spending has reduced substantially from 45% in 2000 to 14% in 2019. However, the proportion of population spending at least 10% of their household income on health, which is the definition of catastrophic health spending, has not decreased. And also we need to recognize that the largest proportion of people impoverished from health spending is in Africa. So we really need to look at more investments for health, but also looking at more health for the existing investments. So this is about the efficiencies in using available resources. And the statistics are not reassuring also, because available health resources not being used efficiently in the African region of WHO led to a loss of US dollars 22.9 billion in 2019. This is due to technical inefficiencies of national health systems. So we need more of the investment, but we also need better use of the existing investment. So it is important to really, as I said, look at the disruptive effect of COVID-19. And it is reassuring to see that from 2020, where 66% of essential services have been disrupted, in 2022, only 22% of the services have been disrupted. So it means that the recovery, the building forward better, is a reality. We have achieved a lot in our countries, but it is important to continue doing more to ensure that health systems are strengthened and made more resilient to withstand the disruptive impacts of health emergencies and other shocks such as climate change and conflicts in fragile and complex settings. It is important to apply the primary healthcare approach, which is one of the accelerators of the Global Action Plan for Health and Well-being, where WHO and UN sister agencies, in total more than 13 partners came together to put in place a coalition to accelerate UHC. So the Global Action Plan is a framework, but we need also to sustain. Looking at the accelerators, and primary healthcare is one of the accelerators. Digital health is one of the accelerators, but we should not also forget health workforce, including community health workers who are at the front line and going to the last mile to perform and to deliver the essential package of interventions. It is also important to look at political commitment, issues of governance, coordination, which are very important, not only at national, subnational level, but also at cross-border, regional, continental level. This is why our engagement with the African Union, in line with the Memorandum of Understanding between WHO and the African Union Commission, but also in line with the African Medicines Agency, commodities and countermeasures are very important. And the goal of reaching 60% of autonomy in terms of vaccine production, for example, in Africa, is very important. We are also engaging in line with the Africa CDC around a joint emergency action plan, whereby WHO and Africa CDC are supporting countries, for example, in preparing response teams that can be projected in 24 hours to respond to any threat or health emergency. So I would like to really stress the issue of collaboration, but also the issue of innovation. WHO has 3 hubs on the continent, one in Dakar looking at data and epidemiological intelligence. That hub is linked with the global WHO hub on epidemiological intelligence based in Berlin. We have a hub in Nairobi looking at logistics and operational support to be able to project tools and materials and also countermeasures where we have epidemics such as Ebola or the recent cholera outbreaks in Southern and Eastern Africa. And we have a hub on innovation to look at the new tools, including vaccines, with, for example, mRNA technology, and looking also at regulatory aspects to make our member states more able, more capacitated to respond and to prevent health security threats. We also are supporting our African Medicines Agency. We supported the ratification of the treaty, and now we are working to support the roadmap and the headquarters now established in Rwanda. I would like to continue with the recent concluded United Nations high-level meeting on UHC, which called on countries to repivot their health systems and service delivery to enhance sufficient and uninterrupted access to quality essential health services, including during health emergencies. The UN General Assembly recommended that health systems functionality and performance should be tracked regularly at national and subnational level to inform timely interventions to improve the health of the populations. This is something that we have learned in responding to emergencies such as Ebola, Marburg. When I was in Guinea, for example, we would conduct intra-action reviews and after-action reviews to make sure that the lessons learned during the response can be reapplied in real time to improve the performance of systems. This can be also done for universal health coverage in time of peace we also need to have a granular look at the systems and their functioning and corrective measures. I think it's important to reiterate the commitment of African member states through several decisions at the African Union Assembly, but also our ministers of health at the regional committees of WHO Afro and WHO EMRO. That political commitment is very important. And I would like to end with a call from the regional directors, Dr. Matshidiso Moeti from WHO Afro, who called member states on the occasion of the UHC celebration for 2023 to advance regional and global efforts that advocate for the reorientation of our health systems to accelerate the process towards UHC through integrated approaches from national policy dialogue, planning, programming, and delivery. And we have talked about the all of society approach, which is so important, and we have experienced that sense during the COVID pandemic. Secondly, to leverage unified global and regional strategic support and formalize commitment from stakeholders, public sector, private sector, community-based organization, faith-based organization, activists and CSOs to sustain UHC attainment at the top of national health agendas, building on the lessons and reflections from the ongoing public health challenges. So I would like to leave you with this and to also mention something that health is a consequence of economic challenges, but health is also a determinant of economic and social development. So let's invest in health. It's time for action. Thank you.
Good afternoon. Thank you most sincerely, Professor.
Yes, so Pamela, I was supposed to pass it on to you.
It's well. Thank you so much for that very incisive review of the state of universal health coverage. And thank you for leading in so well into the following session, which is a webinar that will reflect on the Global Monitoring Report, share country universal healthcare experiences, successes, challenges, lessons learned, and recommendations of actions needed to accelerate progress. We have a host of panelists from diverse regions, as Tabinda had mentioned, and they come from Asia, from Anglophone and Francophone Africa, and they will be sharing their experiences. The 2023 Universal Health Coverage Global Monitoring Report that was released at the high-level meeting on universal health coverage at the 78th United Nations General Assembly meeting reflected the vital role of national political commitment in pursuit of universal health care. And translating these commitments into action, however, has been slow. We're therefore going to ask our panelists to talk a little bit about their experiences in their respective countries. Without further ado, I would like to introduce our first universal health care conversation and distinguished speaker who hails from Uganda, the Pearl of Africa. Her name is Dr. Sarah Byakika, and she's an accomplished professional, currently serving as the Commissioner for Health Services, Planning, Financing and Policy at Uganda's Ministry of Health. Her detailed and impressive bio is in the chat box. I would like to welcome Dr. Byakika at this point to share her thoughts on universal healthcare in Uganda. Welcome, Madame Byakika.
Yes, thank you very much. As the slides come on, I would say greetings, good afternoon here in Uganda, maybe another time elsewhere. And so I'll share our brief experiences in our progress towards universal health coverage. If the slides could be moved, that would be great. And the outline of the presentation will generally be giving us an overview, the UHC status, our financing landscape, and also an insight into the service utilization trends or outcome indicators. I'll then quickly go through our Ugandan UHC experience spanning a decade and a couple of decades, and then the challenges and call to action in relation to the last UN General Assembly. Next, please. A brief background for Uganda. We have currently a population almost 46 million with a gross domestic product of about also 46, by coincidence, billion. And a population living in poverty that is less than $1 per day of about 20%, which is quite high. Our life expectancy currently is about 64 years, with no major difference between male and female. However, we have a high total fertility rate, among the highest in the region, of 5.2 births per woman. Next. In terms of UHC, the current global monitoring report gave us a current status of 49%, which was an increase from 44%, which shows there's some progress that has been made. And however, we still have other challenges in the areas of financing. We have an out-of-pocket expenditure, which is 29%. But on a positive note, the 29% out-of-pocket expenditure is also a 29% drop from the 41% we had in the previous National Health Accounts report. Health insurance in Uganda is still on a very, very low side. It's minimal, with only 2.1% of the population accessing health insurance. And unfortunately, or what is more worrying, that this also dropped from 3.9 to 2.1%. So that shows us that a high proportion of our population is still experiencing high impoverishment due to health expenditure. Next. Still with the financing landscape, when we look at the sources of financing for the total health expenditure, about 46% is funding is from development partners or external financing. And of the in-country financing, 29% is out-of-pocket expenditure or private spending. And then public funding is only about 26%. I've not been able to show the trends, but what we have seen is that the public expenditure has also increased from the previously it was 17% to 26%, which is some good progress. And that is what has contributed to the reduction in the out-of-pocket expenditure to the current 29%. Previously, it was about 41%. So in terms of funding as a percentage of the total national budget, health takes on average 7%, And this has been so across the last 5 years or so. And when you compare with the ABJA target, we are hardly 50% of the 15% ABJA target. So our achievement is still far below expectation. However, in nominal terms, we see that the per capita health budget has some positive trend. So there's some increasing health financing for the per capita health budget, although it is still suboptimal. We know here the target for us to be able to deliver the minimum or the essential health care package as per the WHO recommendation, it is about 86 USD, but we are only at about 22. So that means that the sector is still grossly underfunded, and thus it becomes a challenge in achieving the UHC targets. Next. Despite those challenges, all is not lost. We are really glad or proud to see that we have some positive trends in terms of reduction in maternal mortality ratio. Time does not allow us to explain some of these findings, but at least we have seen a drop from 336 per 100,000 live death maternal mortality ratio to 189. A lot has been going on in there that I cannot explain now, but and the same applies to the trends in childhood mortality, which have over the last 2 decades shown a downward trend. Our biggest challenge is the slow reduction in neonatal mortality. Actually, right now in Uganda, neonatal mortality is the top cause of all deaths in the country. So that is an area that we need to focus on. Next, please. I mentioned that fertility rate is very high in Uganda, and this can be further explained by the low adaptation or use of modern contraceptive methods, where we have only 38% of married women in the ages 15 to 19 using any method. So that is still a challenge that we really need to see, because this high fertility rate or unwanted pregnancies are also one of the factors that contribute to the high neonatal mortality rate, and as well as maternal mortality. Next. In terms of childhood vaccination coverage, there is slow progress. And that's positive trend probably which we had seen in the previous year, though not much, was affected by COVID, where we see a slight drop to 54% coverage with full coverage with all the vaccines. And currently in Uganda, we have about 13 childhood vaccine preventable diseases that we are immunizing against. And so, but we still need to see that we also work on the 2% of the population or children who have received no vaccination. The current slogan is zero no dose. So we have also to look at those. As we look at full coverage, we also still at least 2% who have not received any, and we shouldn't leave no one behind. So that is still also an area to address. Next, please. So what is our experience? As I said, time does not allow, but I'll quickly go through what we have been doing over the last decade or 2 decades to see that we achieve universal health coverage. We started with decentralization of services from the center to the local governments, and this was to increase access to management services, to planning services from the center to the district level. So each district is able to plan and receive resources to deliver primary health care services. This decentralization was followed by establishment of a conditional grant, which is called a primary health care grant. So every local government receives and is entitled, and even every facility, to a primary health care grant. And we also further decentralized under the health services to what we call a health sub-district concept, or establishment of a health center 4-level health facility with at least 2 doctors serving a catchment population of 100,000, and largely to increase access to emergency obstetric and neonatal care services. So this concept has been implemented since 1997, whereby at a minimum, there should be 2 doctors per 100,000 population as minimum. And that also has contributed to the reduction in maternal mortality. It is over 2 decades that we defined the Uganda National Minimum Health Care Package, with services to be provided at all the different levels of care. We have of recent revised this package to take care of some gaps and also to make it more explicit. And the new package takes into consideration the life cycle approach up to covering the elderly whose services were not well articulated in the our previous minimum health care package. But this also helps us to standardize the kind of services that are provided both in the public and private sector. We have scaled up evidence-based high-impact interventions like immunization across the country, with outreaches being conducted using the village health teams. We have integrated community case management to manage some of the common conditions like pneumonia, malaria, diarrhea, and other conditions at community level, and a strong integrated disease surveillance system that is implemented across the country. And this also has contributed to our being able to manage some of the disease outbreaks like Ebola, COVID-19, because these systems were well established and we just needed to reactivate some of them where they were not functional to be able to respond in time. It is quite some time back that we actually introduced village health teams to strengthen the linkage between our health facilities and the community level, and they have been really very helpful in terms of delivering community-based health services. Although this is a voluntary team, we are looking at how best we can further strengthen the community-based approaches using a more motivated and strengthened team, as I'll be talking later. We also realize that availability of essential medicines and health supplies is very critical and is one of the inputs that government decided to re-centralize procurement to ensure quality, but also availability and standardization by introducing a credit line at our national medical stores. So supplies are delivered every 2 months and with a last mile delivery, meaning that supplies are delivered by the national medical stores to every facility, public facility across the country every 2 months. Then we have also, in terms of financing, introduced health facility financing for public and PNFP, direct health facility financing, in terms that every health facility has its own account where funds are transferred directly from the center, that is Ministry of Finance, to a health facility every quarter, and they are able to manage and plan for those funds, a level of autonomy in terms of financial management. 5 years ago, in 2018, we scaled up and institutionalized results-based financing for primary health care as under a project. But beginning this financial year, this has been institutionalized as a financing approach for part of the primary health care grants that go to our local governments or health facilities, specifically for the level 3 and 4 facilities. And this was largely to build a culture of ensuring you pay for results, but also quality as far as the RBF principles are concerned. And also we were envisioning it as a foundation for introduction of a national health insurance scheme. We also have another program called the Uganda Intergovernmental Fiscal Transfer Reform Program, which is spearheaded by the Ministry of Finance. And through this program, we have seen kind of a triple increase in the financing for primary health care over the last 5 years, largely to ensure equity, access, and quality of health services. This program also has supported the construction of health center 3s in our local governments to increase access to quality basic obstetric and primary health care services, and also reach in terms of physical access to health facilities. In the area of human resource, we are glad that the government has made a step towards the issue of addressing the adequacy in terms of the availability in terms of numbers and skills of health providers by approving a new structure or restructuring of the healthcare workforce, where the numbers have actually almost tripled or quadrupled in some health facilities. And what we are waiting for is wage allocation to operationalize this structure. And this will also address the issue of health worker population ratio, which is still a problem. Where we are still grappling with and have not made much progress over the last 2 decades is establishment of a national health insurance scheme. And I think for other members, you know, the issue of stakeholder interest and participation is one of the issues that has delayed us, but we expect that we shall have a final government position in far as introduction of this reform is concerned. Next, as I wind up, really a few challenges, next slide, which are rather similar, or one of them which is so pertinent for Uganda is the fast growing population, not matched by the investments and health system capabilities. We still have persistent high persistence of communicable and non-communicable diseases, deficits in quality of services. Our readiness index is still at 59%, so we still need to invest in the area of inputs and other quality mechanisms. I've already talked about the inadequate financing, limited intersectoral programming to address the social determinants of health, and also capacity gaps in terms of community and decentralized health services. So what are some of the commitments or call to action, interventions that we need to do to overcome some of these challenges? Next slide. These are the actions that we as Uganda committed to at the UN General Assembly as what we need to do in order to contribute towards universal health coverage. Number one is strengthening community-led interventions through programs that build capacity of the community health workforce. And here we are working on introduction of the community health extension workers who are a level above the village health teams, such that we have at least 2 community health extension workers per parish, covering a population of about 5,000. Implementing programs that address social determinants of health, as you all know, and this calls for a multi-sectoral action or approach. We shall continue with improving access and quality of health services through infrastructure development, capacity building, and implementing quality improvement programs. I increase investments in health infrastructure, medical products, technology, and also digitization of health information to improve on efficiency, but also timeliness of reporting building capacity of the health workforce and developing research and development while addressing motivation and retention. And lastly, addressing financial risk protection through establishment of a national health insurance scheme and increased domestic financial allocation to health. The insurance scheme alone may not work for us. Government still needs to increase in line with the Abuja targets, and we expect that will contribute. Overall, government of Uganda is committed to improving the health and well-being of the population in Uganda. Thank you very much.
Thank you most sincerely, Dr. Byakika, for that very comprehensive response on the actions that the government of Uganda has taken in its efforts to improve universal health care for its citizens. Well spoken. We now move, ladies and gentlemen, to the Democratic Republic of Congo. I'm honored to introduce our second speaker. His name is Dr. Mbongani Kabila, who is a physician by profession and is the coordinator of the DRC National Council on Universal Healthcare. Since 2019, he has also been the President's Special Advisor on Universal Health Coverage, working on ongoing universal healthcare reform, before being appointed as coordinator of the Democratic Republic of Congo National Council on Universal Health Coverage in June of this year. Welcome, Dr. Kabila.
Oui, bien, bonjour et merci pour la parole. Je remercie tous les participants. Et je vais donc procéder à une présentation sur le suivi des progrès vers la CSU en République démocratique du Congo. Si on peut avancer à la diapositive suivante, s'il vous plaît. Alors, ça, c'est mon plan de présentation. Donc, nous allons parler des objectifs de la couverture santé universelle sur la base du rapport mondial 2023. L'expérience de la RDC en matière de couverture santé universelle, les succès, les défis, les leçons apprises, ainsi que les recommandations d'action nécessaires pour accélérer les progrès. On peut avancer. Alors, sur la base du rapport mondial de la santé, le rapport mondial 2023, nous pouvons dire que les objectifs que nous sommes fixés sont pratiquement alignés aux recommandations. Donc, c'est assurer des services de santé de qualité sans difficultés financières et des services de santé aussi équitables, si je peux ajouter cela, par le biais de la promotion de la santé, la prévention, le traitement, la réadaptation et les soins palliatifs, avec comme corollaire, bien sûr, un accès équitable et abordable aux services de santé, dans le but d'atteindre les ODD santé 2030, donc les ODD 3, et bien sûr avec une coordination internationale et des politiques nationales contextuelles. L'idée, c'est de voir dans quelle mesure nous améliorons la couverture des services de santé et nous minimisons l'exposition aux difficultés financières liées à l'accès aux soins. Et bien sûr, avec autre objectif, chercher à inverser les trajectoires actuelles, avec des politiques claires pour les dépenses publiques et un engagement pour la CSU au niveau mondial. On peut avancer. Diapositive suivante. Next slide, please. Voilà. Alors, ça, c'est la situation de la RDC en termes de l'indice de couverture des services, la tendance de l'indice de couverture des services, ainsi que l'incidence des dépenses catastrophiques en santé pour ce qui est de la RDC. Comme vous pouvez vous rendre compte, bien sûr, il y a des données qui ne sont pas disponibles, mais pour ce qui est de données disponibles, si vous vous référez à l'indice de couverture des services de santé, vous allez vous rendre compte que, en moyenne, la RDC est à peu près 40% de l'indice de couverture des services. donc des ODD 3.8.1. Et donc, nous sommes en dessous de la moyenne, nous sommes plutôt à 42, oui, c'est ça que je voulais dire. Nous sommes pratiquement en dessous de la moyenne africaine. Et nous sommes passés certainement d'un indice qui était un peu plus faible en 2000, qui était de l'ordre de 21%, jusqu'à 42%. Mais la moyenne africaine est de 44%. Et la moyenne mondiale est 68. De cet indice de couverture des services, vous pouvez vous rendre compte que, par exemple, quand il s'agit de la santé de la mère et de l'enfant, l'indice de couverture est aussi à 42%, plutôt à 40%, alors que la moyenne africaine est à 42%, et le reste du monde est à 43%. Donc, nous, c'est juste pour vous dire que nous avons des efforts à faire à ce niveau-là. Et au fil des ans, entre 2017 et 2019 et 2021, les progrès n'ont pas été significatifs. Alors, en termes d'indice de dépenses catastrophiques, vous voyez aussi qu'il y a une petite amélioration en termes de dépenses catastrophiques des ménages, qui est passé de 5,8 en 2015 à peu près 4,8 en 2021. Et nous pouvons aussi voir que ça, c'est pour les budgets qui ont dépensé plus de 2% du budget du ménage. Et pour celles qui ont dépensé plus de 25%, nous voyons aussi une petite évolution entre 0,84 et 0,6%. Mais il y a eu pratiquement un plateau entre 2017 et 2021, pratiquement pas d'amélioration. Et donc, nous pouvons déterminer ainsi que la couverture des services de santé en RDC est plus ou moins moyenne, mais elle s'approche plutôt d'une couverture faible. On avance. Diapositive. Suivante. Diapositive suivante. Voilà. Alors, quelle est l'expérience et quels sont les succès de la RDC en matière de couverture santé universelle? En 2019, dès sa prise de pouvoir, le chef de l'État, son Excellence Félix-Antoine Tshisekedi Tshilombo, a immédiatement inscrit la CSU dans sa vision comme neuvième palier de son programme quinquennal. Et bien sûr, avec la compréhension que les objectifs à atteindre seraient une couverture de santé universelle avec un système qui consiste à donner à l'ensemble de la population un accès à tous les services de santé dont elle a besoin et des services de qualité suffisante sans que l'on entraîne des difficultés financières. Et pour ce faire, le président a ainsi créé en juin de 2021 le Conseil national de la couverture santé universelle, CNCSU en sigle, qui est un des services spécialisés à la présidence. Et ce conseil est un cadre multisectoriel qui réunit le chef de l'État et 17 ministres sectoriels au niveau du comité de pilotage, et au niveau de la coordination réunit le coordonnateur du Conseil national de la couverture santé universelle avec les mêmes 17 ministères sectoriels, mais au niveau des chefs des administrations, donc de secrétaires généraux. Et ainsi, après sa création, le Conseil national de la couverture santé universelle a adopté en décembre de 2021 le plan stratégique national de la couverture santé universelle. Et à la suite de ce plan stratégique national de la couverture santé universelle, le Premier ministre a créé 6 établissements publics dont les rôles sont assez spécifiques. Et je vais vous donner rapidement une brève description de ces différents établissements de la couverture santé universelle en République démocratique du Congo. Le premier, c'est le Fonds de promotion de la santé, dont le rôle principal, c'est le financement de l'offre par l'amélioration des infrastructures médicales, par l'approvisionnement en médicaments essentiels, et par l'encouragement de la production locale des médicaments, des vaccins, des autres intrants, par la provision des équipements au niveau des formations sanitaires publiques et aussi par la formation des prestataires. Ça, c'est essentiellement le rôle du Fonds de promotion de la santé. Au-delà du Fonds de promotion de la santé, il y a le Fonds de solidarité de santé qui a été créé aussi, qui est notre assurance maladie nationale, et donc qui est essentiellement l'assurance maladie obligatoire, et dont le but essentiel, l'objectif essentiel et le rôle essentiel, c'est le financement de la demande avec le paiement des prestations et donc la protection financière des utilisateurs de soins. Évidemment, il est composé de plusieurs régimes assurantiels, dont un régime pour les vulnérables qui est subventionné par l'État, un régime obligatoire pour le secteur formel et un régime obligatoire pour le secteur informel. Le troisième établissement public ou agence de la couverture santé universelle, c'est l'autorité de régulation et du contrôle de la couverture santé universelle, ACCSU, dont le rôle principal, c'est de réguler et contrôler les systèmes de la CSU, ainsi que les prestations sanitaires en République démocratique du Congo et sanctionner toute non-conformité aux normes. Au-delà de l'autorité de régulation et de contrôle de la couverture santé universelle, il y a eu création d'une autre agence ou un autre établissement public, c'est la COREP, qui est l'autorité congolaise de réglementation pharmaceutique, et dont le rôle principal, c'est de veiller à la bonne qualité des médicaments, veiller à la mise sur le marché des produits médicaux de qualité efficace. Ça inclut aussi la pharmacovigilance, ainsi que la réglementation adéquate de contrôle d'approvisionnement en médicaments. Au-delà de la COREP, il y a un autre établissement qui a été créé, une autre agence, c'est l'Institut national de santé publique, dont le rôle principal, c'est d'assurer la matérialisation de la santé dans toutes les politiques. Et donc, encore une fois de plus, dans le sens de la multisectorialité. Et ainsi, prévenir les maladies et assurer la riposte contre les épidémies et la gestion des urgences de santé, par exemple, la gestion de pandémies comme la pandémie à Covid ou bien des épidémies comme celle à Ebola ou d'autres épidémies auxquelles le pays a fait face. Et pour cela, bien sûr, il travaille en collaboration avec plusieurs établissements ou plusieurs agences ou plusieurs programmes tels que l'Institut national de recherche biologique, l'INRB, qui est un laboratoire de santé publique, ainsi qu'il travaille aussi avec les écoles de santé publique. Pour avancer, le prochain diapositive. Next slide. Next slide, please. La prochaine diapositive.
The slides have advanced. I'm not sure if the screen has caught up.
OK, on peut reculer. Vous êtes allé trop vite. I think you should go back one slide. Yeah, there you go. Alors, le sixième et dernier établissement public ou agence, c'est c'est l'Agence nationale de l'ingénierie clinique et du numérique en santé. Donc, dont le rôle principal, c'est d'assurer la digitalisation du système de couverture santé universelle en RDC et d'appuyer le développement numérique de la santé et de l'ingénierie clinique en République démocratique du Congo. Donc, ça non seulement c'est la digitalisation de tout le système de santé en RDC, y compris, bien sûr, la mise en place du dossier patient électronique et même du système hospitalier informatisé. Dans le cadre de la multisectorialité, tous ces établissements ne sont pas sous une même tutelle. Par exemple, l'ARC, c'est sur l'autorité de régulation et de contrôle de la couverture santé universelle est sous la tutelle du Premier ministre, tandis que le Fonds de promotion de la santé, l'Institut national de santé publique, l'autorité congolaise de réglementation pharmaceutique et l'Agence du numérique et d'ingénierie clinique de la santé sont sous la tutelle du ministre de la Santé, et le Fonds de solidarité de santé, qui est notre assurance médicale nationale, est sous l'autorité du ministre de l'Emploi, Travail et Prévention sociale. Mais alors, pour harmoniser les actions de ces établissements publics, suivant la vision sociale du chef de l'État, à travers le Conseil national de la couverture santé universelle, le président a nommé un coordonnateur et je suis donc dans ce rôle pour le moment. Et mon rôle, entre autres, est celui de coordonner de façon efficiente les actions de tous ces établissements publics de mise en œuvre de la couverture santé universelle. Ainsi, à travers tous ces cheminements, la couverture santé universelle est devenue pratiquement une réalité avec laquelle nous vivons en République démocratique du Congo. Et en septembre 2023, nous avons commencé avec le premier paquet de soins de la couverture santé universelle qui est complètement subventionné par le gouvernement, que nous appelons la gratuité de la maternité et prise en charge du nouveau-né. Donc, nous prenons en charge les femmes enceintes du moment que la grossesse est confirmée. Et nous couvrons les accouchements, nous couvrons toutes les pathologies de la grossesse, nous faisons une consultation postnatale et nous prenons en charge le nouveau-né. Et nous avons commencé avec la ville-province de Kinshasa, mais ce programme est en train de s'étendre au reste du pays et nous sommes pratiquement pour le moment dans 6 provinces. Donc, au premier trimestre de 2024, nous pensons avancer avec beaucoup plusieurs provinces à la mi-2024, couvrir toute la République. En même temps, nous sommes en train de mettre en place les comités provinciaux de la couverture santé universelle et vous allez mieux comprendre quand je vais m'expliciter dans les slides qui suivent. Alors, ce premier paquet de soins va être suivi d'un autre paquet que je vais aussi vous expliquer plus tard dans ma présentation. Si vous regardez à votre droite, vous allez voir le cheminement sur le plan de la couverture santé universelle, les étapes par lesquelles nous sommes passés. Donc, en juin 2021, il y a eu l'ordonnance créant le Conseil national de la couverture santé universelle avec la nomination du premier coordonnateur du Conseil national de la couverture santé universelle. En décembre 2021, il y a eu l'adoption du plan stratégique national de la couverture santé universelle. Et au mois d'avril 2022, au mois d'avril 2022, il y a eu la création des établissements publics de mise en œuvre de la couverture santé universelle. Au mois de septembre, on a nommé des mandataires ou des administrateurs pour ces établissements publics. Et au mois de mars 2023, il y a eu promulgation de l'ordonnance loi numéro 23/006 qui a modifié et complété la loi de la santé publique de 2018. Et enfin, le 6 mars, il y a eu habilitation de cette loi au niveau du Parlement. Pouvons avancer? On avance. Prochaine diapositive, s'il vous plaît. Next slide. Voilà. Alors, ici, c'est juste pour vous parler un peu plus de la multisectorialité de la couverture santé universelle en République démocratique du Congo. Comme je vous l'ai dit, il y a 2 organes essentiels qui composent le Conseil national de la couverture santé universelle, le comité de pilotage et la coordination. Le comité de pilotage inclut son Excellence le Président de la République, qui est assisté du Premier ministre, du directeur de cabinet du Président de la République et des 17 ministres sectoriels, ainsi que du coordonnateur de la couverture santé universelle. Ça, c'est au niveau national, bien sûr. Et au niveau de la coordination, celle-ci est dirigée par le coordonnateur, qui est assisté des 17 secrétaires généraux sectoriels, un délégué du Premier ministre, des directeurs généraux des établissements publics créés, un représentant du patronat, un représentant de l'intersyndicale et un représentant des mutuelles de santé. Et au niveau provincial, il y a la même déclinaison avec le gouverneur de province comme étant le président du comité provincial de la couverture santé universelle. Il est assisté de plusieurs ministres sectoriels au niveau provincial, ainsi que le directeur provincial des différents établissements publics, mais aussi les interventions de la division provinciale de la santé aussi. Alors, au niveau de province, il y a aussi des comités locaux au niveau des différents territoires, avec les administrateurs de territoire ou bourgmestres de communes comme étant les présidents de ces comités locaux. Next slide. Next. Voilà. Et en termes d'implémentation, comme je vous ai dit, nous avons commencé avec la couverture de la mère et de l'enfant pour des raisons simples. Si vous regardez à votre gauche, le tableau qui est à votre gauche, il vous donne une estimation de la mortalité proportionnelle en République démocratique du Congo qui démontre clairement que les affections transmissibles maternelles, périnatales et nutritionnelles constituent le plus grand poids de mortalité en République démocratique du Congo. Et bien sûr, les maladies non transmissibles sont en train de monter aussi. Et pour ce faire, donc, nous avons travaillé avec le ministère de la Santé pour la mise sur pied d'un premier paquet de soins. Si vous regardez à votre droite, vous allez voir qu'il y a plusieurs échelons, plusieurs escaliers. Dans notre paquet de soins, nous commençons avec le paquet de soins numéro 1, qui est celui de la santé de la mère, de la reproduction, santé de la reproduction de la mère, de l'enfant, du nouveau-né, de l'adolescent et la nutrition, et aussi les maladies infectieuses, le paludisme, le VIH et la tuberculose. Mais de façon essentielle, ce premier paquet, il y a un coût bien sûr à ce paquet, mais il est subventionné pratiquement en grande partie par le gouvernement, les fonds du gouvernement, mais aussi par la participation de plusieurs partenaires financiers qui financent par exemple la prise en charge du palu, du VIH, de la tuberculose. Mais pour ce qui est de la santé de la mère et de l'enfant, essentiellement financé par le gouvernement avec quelques partenaires comme la Banque mondiale. Et donc, ce premier paquet de points est un paquet de points qui n'est pas contributif. Mais alors, si nous devons élargir le paquet de soins, il devient contributif par une contribution obligatoire de tout individu vivant en RDC, qu'il soit résident ou citoyen. Et nous allons progressivement étendre ce paquet de soins en allant jusqu'au 3e et puis le 4e. Le 4e, bien sûr, est celui qui pose le plus de défis du fait de son coût, et c'est à cause du coût élevé du traitement, de la prise en charge de l'hypertension et autres maladies non transmissibles. Mais pour le moment, le paquet que nous avons commencé, c'est le paquet numéro 1, qui est en majeure partie subventionné par l'État et par nos partenaires techniques et financiers, et donc qui n'a pas de coût pratiquement pour les utilisateurs des services. On peut avancer. Next slide. Alors, bien sûr, je disais que le deuxième paquet va devoir bénéficier de la contribution des individus en se disant que nous devons mettre en commun les ressources par une mobilisation des ressources qui va être faite par le Fonds de solidarité de santé. Et déjà, le processus est en cours. Nous avons déjà un accord pratiquement final avec les enseignants, par exemple, qui vont tous être inclus déjà dans le deuxième paquet de soins et probablement le 3e aussi. Et nous voyons aussi qu'ils peuvent aller sur le 4e. Mais ce n'est pas une contribution en amont. Donc, avec le principe du prépaiement des dépenses, la mise en commun de ces ressources et bien sûr les achats de prestations et l'allocation du financement. Nous pouvons continuer. Next slide. Alors, les défis rencontrés, bien sûr, par rapport à la gratuité des accouchements ou le premier paquet de soins, c'est qu'il y a le risque, le problème lié au risque moral avec une hyper-utilisation des services sans l'itinéraire, sans respect de l'itinéraire des patients. Nous avons plusieurs niveaux d'accès aux soins en RDC. Donc, nous avons les centres de santé, les hôpitaux généraux de référence, les hôpitaux secondaires et les hôpitaux tertiaires. Mais nous nous sommes rendus compte qu'il y a des patients qui bypassent pratiquement tous les niveaux pour se retrouver au niveau secondaire ou tertiaire sans avoir été référés et qui arrivent dans des situations d'urgence et que nous sommes donc nous sommes obligés de prendre en charge, même parfois pour des accouchements simples qui ne devraient absolument être complétés au niveau de centres de santé. Le problème avec ça, c'est que un accouchement à un hôpital secondaire coûte beaucoup plus cher qu'un accouchement à un centre de santé. Donc, nous sommes en train de travailler pour voir comment gérer ce risque. Alors, il y a la difficulté dans la gestion du transport des patients. Il y a une communication inefficace entre les intervenants. Il y a des retards de paiement des prestataires liés à des vérifications et parfois au délai des banques, parce que les banques n'étaient pas nécessairement préparées à avoir un aussi grand afflux des opérations financières du fait de l'instauration de la gratuité. Il y a la coordination complexe des établissements de facilitation de la mise en œuvre de la couverture santé universelle. Comme vous avez vu, il y en a 6. Et donc, il faut absolument une coordination efficiente pour être en mesure de s'assurer que les conventions avec les PSAC sont signées dans les règles, quel est le rôle de tel ou tel autre établissement dans le transport des patients, l'approvisionnement en médicaments, etc. Il y a la gestion du partenariat avec les prestataires. Il y a aussi les abus des prestataires, j'ai déjà mentionné en partie qu'il y a, au-delà du risque moral, bien sûr, du fait de l'hyper-utilisation de services, il y a parfois des abus des prestataires dans la prescription et même la fraude. Et nous sommes en train de gérer tous ces défis liés à la mise en œuvre de la couverture santé universelle. Il y a les difficultés d'approvisionnement en raison de lourdeur dans les procédures d'acquisition des marchés publics. Et nous sommes en train de travailler avec le ministère des Finances pour voir comment alléger cette démarche d'acquisition des marchés publics. Et évidemment, nous avons, malgré toute notre bonne volonté, ce n'est pas tous les prestataires qui ont accepté d'adhérer au programme au commencement. Donc, nous avons pu commencer avec 3 quarts plus ou moins des prestataires. Alors, les défis rencontrés en rapport avec le démarrage effectif des autres paquets de soins au régime d'assurance maladie, c'est le défi d'adoption par certaines parties prenantes, la concurrence avec les assureurs privés du fait de la mise en œuvre de l'assurance maladie obligatoire. Il y a aussi, bien sûr, la finalisation et la validation des mesures d'application de l'ordonnance loi de mars 2023, qui est assez récente. Et donc, il y a des tests d'application qui doivent être pris, tels que les décrets de Premier ministre et des arrêtés ministériels qui ne sont pas encore pris, ce qui rend toute l'application de la loi un peu hésitante pour le moment. Il y a la nécessité d'exécuter plusieurs études en implémentant la couverture santé universelle, en particulier l'assurance maladie obligatoire, telles que les études actuarielles, les études de catégorisation des populations, le paquet de soins, etc. Et il y a aussi des défis et retards dans l'organisation des dialogues avec certaines parties prenantes et des réflexions sur le financement des établissements de facilitation visant à garantir 2 ans de financement avant d'atteindre une autonomie financière. Je crois que j'ai fini pratiquement. OK, on avance. Je crois que nous allons passer aux recommandations. Je crois que c'est mon dernier slide et j'aurai fini. Next slide, please. Alors, leçons apprises. Donc, il y a besoin d'un ajustement constant parce que c'est un système apprenant. Il y a besoin d'un engagement fort des dirigeants politiques. Il y a besoin d'une mobilisation de ressources durables qui est nécessaire. Les infrastructures, ressources humaines et accessibilité géographique doivent être renforcées et améliorées. Il y a besoin de l'intégration coordonnée des soins de santé, besoin d'impliquer les communautés, et c'est un besoin essentiel. Il y a besoin de donner des qualités d'une surveillance. Il faut des stratégies flexibles et adaptables, la nécessité de la mise en place de mécanismes d'accès financier pérenne et équitable. Et une coordination efficace et cruciale, y compris dans le cadre de la santé, dans toutes les politiques, donc l'approche multisectorielle. Et donc, pour l'avenir, comme recommandation, nous dirions qu'il faut renforcer l'engagement politique, mobiliser des ressources durables, prioriser les renforcements des systèmes de santé, promouvoir l'intégration des services, renforcer l'engagement communautaire, améliorer la collecte des données et la surveillance, maintenir la flexibilité et l'adaptabilité, élargir l'accès financier dans une approche visant à atteindre l'équité, renforcer la coordination des acteurs, établir des processus d'apprentissage continu et d'évaluation. Je crois que j'ai fini. Et donc, je vous remercie pour votre attention. Merci.
Merci beaucoup. Thank you very much, Dr. Kabila, for that comprehensive response. We now shift gears and move to the continent of Asia, and specifically Bangladesh, where our third guest, Dr. Shamsul Haq, the Program Manager for Adolescent and School Health Programs, Maternal, Newborn, Child Health, and Adolescent Health, in the Directorate General of Health Services, Ministry of Health and Family Welfare, comes from. Dr. Hawk has 16 years' experience in civil service under the Ministry of Health and Family Welfare, and he's a medical doctor by profession with an interest in epidemiology and health economics. Welcome, Dr. Shamsul Haq.
Assalamu alaikum. It is Dr. Mohammad Shamsul Haq, Program Manager at Adolescent and School Health Program. On behalf of Ministry of Health and Family Welfare, Bangladesh, I am welcoming my presentation. Next, please. Here is the presentation outline, that is status of universal health coverage in Bangladesh, challenges faced, status of the global monitoring report. How can global community help accelerate in universal health coverage in our country? Next, please. This is a question. Bangladesh is left behind on the path of universal health coverage. Current status of universal health coverage in Bangladesh showing we are at 49 out of 100. It is quite behind on expected range. Population affected by catastrophic health expenditure. People improvised by healthcare costs. Current public health expenditure only 0.7% of the GDP. Next, please. Next, please. Next, please.
I've attached the slide to the challenges.
Yes. It is. Thank you. Challenges in achieving universal health coverage. Inequitable access is the major cause of achieving universal health coverage, that is geographic and socioeconomic disparities. Limited urban primary health care system provided by the Ministry of Health, Family Welfare. Less number, inappropriate skill, as well as mixed and inequitable distribution of HR. Suboptimal accountability and lack of good governance. Diseases are not optimally addressed here. Inadequate budget for primary health care, that is in case of preventive care, it is very much limited in our country. Frequent stock out of essential medicine and other supplies, which is provided by the facility. Insufficient equipment to deliver the quality of services at primary level. And last not least, financial protection. It is the high out-of-pocket expenditure in case of health services. Next, please. Here showing some graph. There is a monitoring indicators in case of Bangladesh in global scenario. We are quite behind in this matter. It is 57% out of, it is showing that 2020 indicator, that is 57 need acceleration. And we have 4 domain and 14 indicators where maternal health, child health, and hospital bed density and health workers density, we are quite behind here. We need accelerated in these matters. Next, please. Comparing 4 countries here, we're showing the essential health services in member states of the Southeast Asia region, 2010 to 2020. Here's the coverage index. We are at 49, Bangladesh. In relation to Nepal, we are similar to Nepal, but Sri Lanka and India is quite ahead in relation to Bangladesh. Next, please. It is a success story in case of immunization. Here showing 2016 national coverage was 82.3%, whereas it increases in 2019, that is 83.9%. Recent 2022 data showing here is not reflecting here, but it is quite ahead, that is showing the 92 to 94% is the coverage in national immunization by the age of 12 months among 12 to 23 months of old children. Here, the district, we have the 64 district where yellow zone, that is 80 to 84% coverage is 35 was at 2016, whereas in 2019 it becomes 30. But light green zone showing in the map, that is 14 was at in 2016, whereas we are at 20 district is 85 to 89% coverage in 2019. Next, please. Here showing proportional of mortality in Bangladesh 2016. At that time, we have the population 1.63 lakhs. Among them, 8,56,000 were dead from the NCD, accounting 67% of the all death. And it compromises that consisting 30% from third cardiovascular diseases, 26% from the communicable maternal, perinatal, and nutritional conditions, cancers accounting 12%, where other NCDs accounting 12%, and chronic respiratory diseases, that is the CDs, communicable disease, that is 10%, and 3% from the diabetes. Next, please. Here, the consumption of the contraceptive method, especially we know that in our customized, the percentage of the married women aged 15 to 49%. Any sorts of modern methodology is consumed by the women, that is 55%. Among them, pill accounting 27% and injectable 11%. In the permanent method, where female is using more ahead than the male, that is 5%, whereas male sterilization only less than 1%, and IUD accounting 1%. And other traditional method is consuming the among the population is 9%. Next, please. Next, please. Slide change. No, previous slide, please. Previous slide. This is the actually short-term temporary method already mentioned. I have here long-acting 8%, total 50%. Next, please. This is we have the 8 administrative division. This graph is showing here that among the divisions, highest level of contraceptive method is used at Rajshahi and Rangpur, that is 61%. Whereas lowest in red zone, this is just put the key forward, you can say here, that is Chittagong and Sylhet, where on less than 50%, but 53 to 59% in Khulna, Borishal, Dhaka, and Mymensingh. Please, next, please. Yes, this is the Chittagong Sylhet showing the still below 50%. Next, please. This graph is, please, previous on. Yes, here. Here, domestic government's spending on health among Southeast Asia region member states. Here, spending in 2018, domestic government spending on health as share of total health expenditure less than 5%, whereas health share of domestic government expenditure less than 10%. In relation of other countries, quite ahead, especially Thailand, Indonesia, Maldives, Sri Lanka, Bhutan, far better than our country. Please, next, please. Next, please. This is the financial burden on our country, that is current health expenditure 2018, mostly accounting the out-of-pocket expenditure around 70 to 75%. Only Myanmar is quite alarming sign, showing the alarming sign here, but Bangladesh is quite behind in the public service expenditure, especially in health expenditure. It is account out-of-pocket expenditure more. Next, please. Two graphs showing a 2009 to 2016 graph, that is the proportion of population spending more than 10% of their expenditure on health. Here, national and rural expenditure more or less same. That is the urban is quite good, but rural and urban, rural and national graph showing more than 10%, where proportion of population being pushed under 1.9 capita US dollar poverty line due to health expenditure, that is out-of-pocket expenditure more in our country. Next, please. Though many bad indicators showing in case of universal health coverage, but we have a success history, that is the high immunization coverage. Our Honorable Prime Minister awarded as vaccine hero by Gavi. Polio eradication is the major improvement indicator in our health facilities. Other is maternal neonatal tetanus elimination. Malaria, hepatitis B is controlled, and reduced child and newborn mortality and achieved MDG before 2015 has been already achieved by our country. Now we are on the path of achieving SDG. Especially, we are doing on the expansion of health service delivery network and substantial increase in health human resources. Next, please. Suggested roadmap for UHC universal health coverage in Bangladesh, that is increase public financing, additional resources towards the primary health care, enhance efficiency in fund utilization. Urban primary health care is designed in next sector program. Facility readiness, that is HR infrastructure, medicine and equipment has been allocated accordingly. Digital health information system is strengthening, and a strong monitoring system is doing on by our country. Governance and accountability has been enhanced. Next, please. How can global community help accelerate universal health coverage? This is the last slide of our presentation. That is, we can do around accountability, financing, and good governance, collaboration for knowledge sharing and best practices. Financial support and investment in health infrastructure will be awarded. Strengthening of health system globally, and definitely SDG tracking is the major concern of our government. Thank you all.
Thank you most sincerely, Dr. Shamsul Haq. And we now move to our final panelist, Mr. Judy Kyle Elidijde, who is the UNFPA representative in Bujumbura, Burundi. And we have a question for him. As the resident rep of UNFPA in Burundi, can you share with civil society community your efforts to support countries to take action to accelerate universal health care? Over to you, Judy Kyle.
Thanks, Pamela. Thanks to all other panelists. Last but not least, I'll try to keep short in the time to allow people to have the conversations. So, likewise, other sustainable development goals, the CSOs are also involved into those global issues. And as we all know, the SDG target 3.8 is about universal health coverage, and we cannot reach health for all if some part of the actors are excluded, and civil societies play an important role. As the UN, I think one of the critical parts of our role in this process is our convening roles and normative roles in that discussions to allow the CSO to play their part. Globally, if you look at the report and also some of the key elements, the roles and the effort of the CSO have been articulated around the points that are raised here. The first one is their role in advocacy, both at global, regional, and country levels. And this advocacy is meant to increase political will and accountability from government, and at the same time to help communities keep in mind their priorities in terms of health, to contribute to improve the services as well as the public health system as a whole. Second element of the effort made by the CSOs into this process is ensure that the health system strengthening take into account the health and care workforce. And this is very important because ensuring the decent conditions of the health care workforce and their working conditions is an element that is central in achieving UHC, as we all know. Some of the CSOs are also part of the service delivery. And as they know the communities based on the work that they do, they contribute to increase and enhance the access, the equity, utilizations, and financial protection and the quality of care. CSOs contribute at the same time on assessment, evaluations, budget formulation and approval, and also contribute to coordinate some of the efforts to ensure that some of the root cause are put in light and allow people therefore to alleviate those barriers. And at the end, the CSOs contribute also to influence the relevant stakeholders to ensure that relevant and sufficient resources are aimed to contribute to universal health coverage by ensuring the proper allocations of resources toward health services and expenses. Next. Some of the key recommendations that can be highlighted here is, first of all, what is the environment that contributes to allow CSOs to play their role? So for the government, it's very important to ensure that the legal framework and the policies are conducive and protect CSOs in the process of their engagement into the achievement of the universal health coverage. Because if they have to play their complementarity role and their accountability role, they have to be free. So without that free zone and free space, it'd be very hard for them to play that role at country level as well as at global and regional level. One of the key advantages of the CSOs also is, as they know the communities, and they also know the people they serve, they can help targeting those much more left beyond and further left beyond in order to accelerate with specific actions the implementation of the UHC, and that's very important. And that can be only done if there is proper coordinations, and the UN play a convening role in that coordinations, as well as making the linkage with the different governments. If you look at the trends in the world now, it can be very difficult not to connect the implementation of the universal health coverage with other global priorities and megatrends. So climate change, population dynamic, shift, geopolitical pushback are important to ensure that the appropriate pace of the UHC is made at country level, because global events are interconnected, they influence local decisions. So without taking that into considerations, we may lose some of the focus of the implementation related to the UHC. And the last point that I want to raise is UHC is not meant to be implemented only in time of peace. So in time of development. So bear in mind and connecting the continuum of humanitarian development and peace is quite critical in the implementation of the roadmap of country roadmap related to UHC. And in this role, the UN can play an avant-garde role and will continue to support government and CSOs to connect in order to ensure that at country level, we are able to continue this rollout of the universal health coverage. I'll stop there and allow questions to the public. Over to you.
Merci beaucoup. Ladies and gentlemen, we've come to the end of this panel, and we now, although we are running a bit late by over 10 minutes, I would now like to welcome responses from the panelists to some of the Q&A for the next 10 minutes, with your permission. This particular question is from Issa Sar, and it's directed to Dr. Sarah Byakika. And the question is this: measures of service coverage comprise the full spectrum of essential health interventions and their associated costs. And this can be limiting in lower and middle income countries where, because of resource constraints, a lot of healthcare needs are either limited or missing. How can universal healthcare be measured in such settings? Over to you, Dr. Byakika from Uganda.
Why is it?
don't know what's giving, not sure around in the top. It is not so clear.
Sorry, it was not very clear, but you are saying that measure of service coverage comprise the full spectrum of essential interventions and their associated costs. I don't think that's what we use to measure service coverage. Service coverage, we have clear indicators that are clearly defined. And for example, our UHC index is based on well-defined indicators which are monitored. And you very well know that the UHC index is defined for countries or measured for countries through other mechanisms like through World Bank and other partners. For us in country, we also set our own targets, but we also base on indicators that have been clearly defined based on the WHO indicator indicators and also the SDG indicators. We, as much as possible, avoid using compound indicators. Like I can't work out the UHC index for my country because it's a compound indicator. I just await for the WHO, World Bank, what they provide. But on routine basis, we have indicators that we actually monitor. Others are monitored through community surveys, and we cannot report through our routine facility-based monitoring system because it's not comprehensive. For example, maternal mortality, child mortality, as I demonstrated there, is based on demographic health surveys, and demographic health surveys are conducted using approved methodology across with review by external peers. So we have, as much as possible, for example, in Uganda, when we go to global reporting, SDG reporting, we don't base on our routine information system, but we use population-based survey data, which has been collected using globally approved methods. Thank you.
Thank you all. In the interest of time, we will respond to the questions in our feedback to all who are taking part in this wonderful event. And I will now have to hand over to Pathfinder's President for Africa, Madam Lydia Saluku, to close. She brings nearly 25 years of public health experience in reproductive maternal health and organizational management in Africa. She has worked with the Population Council, the HIV and AIDS Private Community Initiative, as well as Planned Parenthood Federation, covering West and Central Africa. At this point, I welcome Madame Lydia Saluku to wrap us up. Karibu.
Thank you so much, Pamela. Thank you. I think today we have a great panelist and great meeting. And like I want to say, I have it's a good moment for me to take the floor and say thank you. Dear government representative of DRC, Uganda, and Bangladesh, dear UN representative through Professor Ki-Zerbo, Director of WHO Office at African Union, GSCSO members through Smita Sadavisan of UHC Civil Society Engagement Mechanism, dear colleagues, especially Pamela Unduso, who gave us the honor by moderating this conversation. Ladies and gentlemen, it is with a lot of emotion that I take the floor this afternoon to make the closing remark to this virtual platform intended to mark the commemoration of this 2023 UHC Day celebration, observed under the theme, Health for All, Time for Action. And this means important for us as Pathfinder. For those who might be new in these activities, please be informed that Pathfinder celebrates this event every other year, and each time it is a great excitement that we note that much is being accomplished despite the difficult journey through eliminating out-of-pocket cost in accessing health services in a context marked by some countries who are really struggling to recover from COVID-19 pandemic impact. Yet, through your voice, you have also noted that we did some progress in countries, but also globally. We did progress, but there is a lot stay in our end. And there is a much is left to be done. And it's where I think it's really important to continue to support our community, our government, and the global community to continue to really achieve our goals on not letting anyone not accessing to health services. I really want to pause here to come back on what WHO painted in terms of WHO, but also the CSEM and country experience show us through our estimated speaker from DRC, Uganda and Bangladesh. It's very clear we have a lot to do, and it's very clear we need to be very close and supportive to the countries and really work together and in the end to be sure we are able to make this happen for women, youth, and children. This is very important to help realize the commitment of the different countries. During to our outcome for this event, which intended to increase awareness about UHC Global Monitoring Report, and also sharing knowledge and insight on countries' action to achieve UHC. I think at this time, we are about to quit this event. I am convinced that this outcome has been met. And I would like really to appreciate our esteemed speaker for the quality of the work put into the presentation. Congratulations for this presentation. I want also talk to my colleague of Pathfinder. Please use this session as a point of contact for productive partnership to be able to work together to achieve what the countries are planning. And I want here to reiterate the commitment of our organization to continue supporting government, regional bodies, and community to achieve UHC for women, children, and all the population, and to be able to build, working together, a strong and resilient health system. For all, we raise awareness on the need for strong and resilient health system to achieve universal coverage. Ladies and gentlemen, I want really to say thank you. Thank you for putting these important events. Thank you for this joint effort, staying all this time to share and to build our awareness and knowledge about UHC. I want really to say a special thank you to all the esteemed speakers, and special thank you to Pamela. Merci and bye.
Bye.
Thank you, everyone.
Thank you.
Thank you.